Welcome everyone. Good afternoon on this sunny day in New England. My name is Andres Zinchuk. I'm a pulmonary critical care and sleep doc here at Yale and one of the co-founders of the New England Sleep Seminar Series, which is a educational consortium that brings us the latest and greatest in clinical and scientific advances in sleep medicine for the New England region and really across the United States and oftentimes abroad. And so it's a collaboration between Yale School of Medicine, our sleep center, the sleep center at Beth Israel and Mass General and Tufts and Boston Medical, Brigham Women's. As of last year, the Brown School of Medicine. And so we've covered a fairly large range of topics in the last 5 years or 6 years now, I should say, since we've done this. Anything from wearables to equity in sleep care and you know specific things about auto CPAP algorithms and how they influence our patients' outcomes. And today we're going to talk a little bit about transition from pediatric to adult sleep medicine. And so as a bit of a summary, that since our inception, we've had over almost 4,000 attendees for the duration of this conference. And I think this is an underestimate since a lot of people log in from, say a room with more than one individual in there. So we're pleased to have this success. And, on average, we have about 75 to 80 individuals per session. So this is a high impact event. And so I'll stop here. I'll stop sharing my screen and I'll invite Dr. Vesna Buntak from the Brown Warren Alpert School of Medicine to introduce our speaker today.
Thank you very much. It is a true privilege to introduce Dr. Richard Millman, whose career has shaped sleep medicine in Brown and far beyond. Dr. Millman earned his undergrad degree at Yale and his medical degree from University of Pennsylvania. After completing residency at University of Michigan, fellowship training in pulmonary medicine at Penn, he joined Brown, where he serves as professor of medicine and pediatrics.
Okay.
No, I am not done. For nearly 4 decades, he has led sleep disorder centers at Rhode Island Hospital and across the Brown Health system, while training generations of physicians who continue to shape the field of sleep medicine and beyond. Nationally, Dr. Millman has served on NIH, NHLBI study sections and advisory boards, including the National Center on Sleep Disorders Research, and as a member of NHLBI Clinical Trials Review Committee. Within the American Academy of Sleep Medicine, he chaired the Education Committee and served on Standard of Practice Committee, helping to develop foundational practice parameters that define modern sleep medicine. He also co-founded the Northeastern Sleep Society and has led leadership roles within the ATS as well as chest physicians. His scholarly work includes more than 200 peer-reviewed publications, editorials, book chapters, and invited reviews spanning obstructive sleep apnea, adolescent sleep health, PAP adherence, sleep and pregnancy, just to name a few. He has served as principal investigator and site PI on multiple NIH-funded trials, including landmark studies examining sleep apnea and obesity and type 2 diabetes. Without Dr. Millman, sleep medicine at Brown would not hold the place it does today. His leadership built a foundation on which many of us now stand. Now, please join me in welcoming Dr. Richard Millman.
Nice. Thanks. That's great. Can everybody see the first slide? Because I think may have gotten bumped out. Can you see it at all?
You
We,
have
we
to
cannot, so you
reshare.
may want to reshare. Yeah.
I'm not, okay, wait a minute. I sort of got bumped out of Zoom.
Oh, that was, I'm the bumper. I
Yeah, the
apologize
bumper.
for that.
Let me try to figure out how to do this. Um, Took me forever to get in, so let me just see what we can do.
So if you go to, share and then you can share your
I got to get
desktop.
out. I got to get out
Uh,
of this, I think. Okay. So let me get out of the PowerPoint, I think. That's what I'm gonna have to do. Well, I'll start talking about what's around here. So I am an anomaly in that um, I'm an adult sleep physician doing pediatrics. And in fact, you could almost look at it, I'm sure, from the pediatric standpoint, that I'm a bull in a china shop. And um, let me see if I can get out of this. And what happened was when I got to Brown, I was the only sleep physician for miles around. The only other real sleep labs were in Beth Israel, Children's, Dartmouth, maybe a little at Yale. I wasn't even convinced at that time there was. And um, I'm actually going to have to turn my whole computer off, I think. Um,
No, you shouldn't have to close your computer. You should open your PowerPoint.
yeah, that's the problem. Is let me just get into this again. Can you still hear me?
Yes.
Okay,
Yes.
that's good. Um, so Judy, initially I would be seeing kids with big tonsils, kids with sleepwalking, having no idea what I was doing. And I would call up my friend Dick Ferber and I would say, what the heck do I do? And one of the things he was very helpful with was if it sounds like a horse, don't consider it a zebra, and how we deal with there. Okay. So, and how you would deal uh with like sleepwalking and stuff. And then we decided that perhaps what I should really do is we should hire a sleep person. And actually, the sleep person we used was Tom Anders. He came by and we had him for a while, and then homegrown talent. Judy Owens became the sleep person, and after about 20 years, and I was covering her, she decided to go to national and then children's, and I said I would help out our psychologist and then after 3 months, they said, no, you're stuck, you're doing it. So I've been doing it literally for 15 years
So
with
Dr.
three
Millman, I
versions.
think if you go to your Zoom app on your screen, that's a little blue icon. Yeah, click on that.
Yeah,
Yep. Oh, no, no. Down at the bottom, strip next to the PowerPoint. Yeah, so click on that. Yeah, click
right.
on
You
this
guys are helping
screen
me
on
out.
the right.
Yeah.
Great. Click on that one. Yep. Excellent. And then you can stop sharing and then you can restart sharing.
Okay, wait a minute. I see.
Do you have two screens open?
Yeah, I have all you guys, and I'm trying to also.
Uh,
Um, wait a minute. I know what I got. It'll be a second. Sorry. I mean, I was perfect
oh,
until you took
oh, I'm
over.
sorry. I didn't realize that would cause so much trouble.
No, no, it just knocked me
Um,
out. So, tell me what to do at this point. I have
okay, so let me see if I can.
just walk me through it. Sorry, I'm screwing everybody out here.
Oh, that's okay. So I just stop your screen sharing. So now
Right.
you can go back to your Zoom and do screen sharing again, and then you'll just pick your PowerPoint as the screen to share. And
Okay.
or if it is easier, you're welcome to share the slides with us and we can
You have the
play them.
slides, I think, but let me just try to. I'm sorry, which is like ridiculous.
Is your PowerPoint presentation open?
It's open, but it's just not on play. It's just not. It's just open. Um,
So when you go to share, you should be able to highlight that.
right, and I understand that. And that's the thing is, I can open it up. I'm not getting into the Zoom though at the same time. I'm sorry. Which gets very frustrating.
Oh, that's okay. Deb, do you have the PowerPoint?
I have a draft version. I didn't get the final
That
version.
is the final.
Oh, great. So Deb, if you want to share it, that would be great.
Yeah, I'm
Deb,
really sorry. It just
yeah,
said,
Deb, to be on the safe
I
side, do you want to
I
send
won't.
it to me if you have to leave?
Yeah. Yeah. Okay.
We'll get there. This is a solvable
no, no.
solvable
I mean,
challenge.
it's tough because I literally we were all set. So it's not your fault. I'm not. This is not something I would normally do because
Yeah, no, these things are totally complicated. That's right.
Just sent.
Okay, I will let you know when I get it.
And I really apologize to
Oh,
everybody.
that's good. So you can, Dr. Millman, you can keep talking, and then Vesna, once she gets the PowerPoints, she will put them
Perfect.
up there and fire it up.
Okay, so basically 15 years ago I became a pediatric sleep doctor. And having an adult perspective, and I don't know how many of you are adults who do pediatrics or pediatrics who do adults, the problem is it's really two separate worlds. And because it's two separate worlds, we really are talking about having talking apples and oranges. And typically when a kid hits the adult sleep world, you have diagnoses that they may have set up like night terrors or sleepwalking or sleep apnea, whatever. And suddenly that teenager at 18 sort of becomes somebody who is in a different definition. It's sort of like, I don't know if you've ever, I certainly have, taken care of pediatric kids in the rest who have ventilator issues or whatever, and have gone from the Hasbro Children's into the respiratory care unit at the Rhode Island Hospital. And the shock is the nurses don't know how to deal with mothers. They don't really know how to deal with a 20-year-old who really can't communicate well. And are suddenly dealing with the pediatric case. And unless you've done med peds or have had any experience in pediatrics, you really don't know what you're dealing with. And it's just because the care they get, whether it's at the pediatrics part at Yale or at Children's or in Hasbro Children's Hospital, is really a totally different approach to the world. And in fact, when I would go to pediatric sleep meetings and raise issues, I'm 100% not one of them. 100%. And again, this talk sort of does that. And are you my slides up at all, Vesna? Or
Yes, your
Yes, they
slides should
are.
be up.
Yeah, and
okay, so I can't. Should I
the
be
folks
able to
can see them.
see them, or are you just going to advance screen, or
So
what?
I will advance the screen, but you should be able to see them if your Zoom app is up.
Uh, minute. Okay, I can see it. Perfect.
Perfect.
All
Right.
right. So this is the typical CME disclosure thing. I really have no conflicts with this at all. So if we could just go on to the next one. Thanks. So the learning objectives are kind of different. This is not a talk where I'm reviewing the latest thing with the hypoglossal stimulation. This is sort of a gestalt. How do you deal with this thing? And one of the first things is to accept that the patient age is simply a number. Two, sort of try to be reasonable in how you approach results, both in adolescents and young adults, and also how do you make those decisions in regards to numbers or things that you think you know or that you're getting in front of you. Next slide. So let's go look at the definition of pediatrics. In 2019, the American Academy of Pediatrics, sort of the place in pediatrics, stated that pediatrics is a specialty in medical science concerned with the physical, mental, and social health of children from birth to young adulthood. And there's literally no age cutoff. So a pediatrician, as you know, could keep your kid at age 18, 21, whatever. Next slide. Can you advance things? What about the sleep field? Well, the American Academy of Sleep Medicine has clearly in multiple places classified pediatric sleep up to age 18. And this is both in the International Classification of Sleep Disorders and the American Academy of Sleep Medicine manual for scoring sleep and associated events. Thus, it's an interesting issue. Definitions and how you approach things literally change when you take a 17-year-old, 364-day person to go to 18 years. Next slide. Now, part of the issue comes up is why is that? Well, oftentimes pediatric sleep medicine and adult sleep medicine are in separate departments and maybe even separate buildings. Look at uh, the Harvard, where children's has its own place. Also, in regards to how things. A lot of the people doing sleep research are coming from either pure pediatrics or pure adult sleep disciplines. And you'll see as we go along, there's actually probably some, unfortunately, in every field, some investigator bias. The next slide. So let's talk about sleep apnea. So how we define kids events and how we define adult events have sort of evolved. So the classical thing is for kids that events are 2 breath lengths. In adults, we know that's arbitrarily 10 seconds. And for the longest time, we sort of, kids were up till age 18. And more recently, in the American Academy of Sleep Medicine Scoring Manual, there's a statement that children 13 years or older may use the child criteria or the adult criteria if they have an adult body habitus. And that's sort of a change because literally in the past, it was 18 years. That's it. 0 to 18 as a kid. Next slide. Now, hypopneas are interesting because in children, it's a peak drop in the nasal pressure transducer excursion for at least 30% of the 2 breath lengths with a 3% fall in oxygen saturation or an arousal. Now, we know in adults that also exists, so it's 10 seconds, and that's the one we all use. However, we also know that Medicare is behind the time and they sort of want a 4% fall in oxygen saturation. Next slide, please. So there's basically concordance in regards to a sense definition of AHI in regards to how we do it with the 3% fall in oxygen saturation for hypopneas and or arousal. The difference in little kids is 2 breaths, in adults is 10 seconds. However, again, we're dealing with this thing that's out there clearly in the literature that an AHI of 1 is the definition of kids up to 18, and the definition at 18 or older is 5. And what do you do in between? Can I have next slide? Because we have a problem, don't we? I mean, how can you jump from one to the next with nothing transitioning? And part of the reason we got there is that there's been a limited number of studies, small sample sizes. Some of the studies, if you look, are in obese kids or kids that snore. And a lot of the early studies have been discounted because they use thermistors. Now, we well know that nasal pressure transducer is how you do hypopneas, right? Apnea is by thermistors. But the thing is, just because on one of the older studies is done with thermistors and it's calling hypopneas doesn't mean you discount it. Because if you can call a hypopnea with a thermistor, well, obviously you would be counting it with a nasal pressure transducer. And I'll be very honest, this is where the bias comes in. Mary Karskan and I both got to Brown the same time in 1985, and we had an RON. And the RO1 looked at adolescents and it looked at young adults. And lo and behold, this is Christina Siebel wrote this article, first article. These are normal kids, non-snoring, not overweight. And lo and behold, we looked at the 10 to 17-year-old boys. They had an AHI running from 0.2 to 6.2, and the girls 0 to 2.8. So if you sort of discount that, oh, they can't be hypopneas because it's done by a thermistor, then that it doesn't make sense with your definitions because clearly something is happening as kids become adolescents, and you can't jump from 1 to 5 literally because they turn 18. Next slide. So if you look at the results, a lot of sleep physicians who are dealing with this don't know how to score those. Do you call an AHI of 1 in a 15-year-old? Is that really sleep apnea or not? ENT for doctors, and it certainly happens with our big pediatric ENT group, they're very hesitant just because an AHI is 1.2 to take out tonsils in a kid. They really believe that it's sleep apnea. And in fact, the only way we really deal with it is hopefully we have enough symptoms, plus we get the moms now with their iPhones or the dads to actually record snoring and stopping breathing, because how do you deal with that number? And then the other thing that's really interesting is if you set up CPAP in a 16-year-old with an AHI of 1 or 2, once they turn 21 and they need a new machine, well, that the insurers aren't going to cover sleep apnea necessarily because they're using a number five. So again, we're in this world where we're very arbitrary on the pediatric side, very arbitrary on the adult side on what we call things, and a lot of it's based on the things we've talked about. So clearly, this is something the field really needs to look at. Next slide, please. So, what about testing? Well, children and adolescents, especially in Rhode Island, they all get full polysomnography. We know that home studies for sleep apnea have been investigated, but in Rhode Island, unless you're 18, you don't get a home study. Now, is that a bad thing? I'm not convinced it is because there's a lot of kids out there who have restless legs and periodic limb movements. So I don't, when I do pediatric studies, I actually want a full one. And in fact, getting a full study in somebody who's 18 or 19, where you know that we're dealing with hypersomnia, the insurer's office will say, no, you need a home study. So there is a difference in technique availability for the different ages. Next slide. And what about treatment? Well, the treatments are different, as we know. We oftentimes push tonsils and adenoids. Basic treatment in kids is weight loss, body positioning, keeping the nose patent. Where after 18, you're using weight loss, positive pressure therapy, adjustable appliances, saying don't drink alcohol, and you're still trying to keep the nose open and maybe doing some positioning. But the question comes up is what happens if you have an 18-year-old with enlarged tonsils? Is it an adult or a kid? Next slide, please. So I'm going to give you a clear-cut patient, and it's sort of different than the phenotype discussions from Yale, but this let's call it phenotype. So I'm going to call it what phenotype wins. So you have an 18-year-old kid who just graduated from high school. He's working, didn't go to college. Long-standing history of snoring, observed apneas, and choking arousals. When he was a kid, he sleptwalked. He's tired when he gets up, even with 9 hours of sleep. But when you question him, and of course, again, you're dealing with a teenager, he says, "Oh, I never doze off, so his Epworth was only 1 out of 24." Did a home sleep study on him, and he had 35.2 events per hour study. Lowest sat was 73%, and he spent 4.3% of the recording under 90%. So this is real sleep apnea. Next slide. His phenotype, one, is he's like his mother. He's 5'7", 211 pounds, BMI of 33. His mother's overweight with a BMI of 39. She has snoring, disrupted sleep, poorly controlled hypertension, Epworth of 10, and does have sleep apnea. On her study was 14.3 events per hour. And she's been one of my successful CPAP patients, but she can't lose weight. So that's phenotype number one. Let's look the flip. Let's go to phenotype number two. And that's a picture. That's not him, obviously, but that's sort of the body habitus of somebody his size. I went on the internet and found that. Okay, next slide. Phenotype number two, take the same guy, and that's him, and literally he has 4+ tonsils. And again, I took this picture from the internet, but trust me, his tonsils are this big. So, and he's had a history of recurrent strep throat that getting him that. Next slide. So, which phenotype are we treating? And that's a big question because there have been reports in Rhode Island, and there's very few adult ENT doctors who like to take out tonsils and adenoids because of bleeding and pain and stuff. So, next slide. So, phenotype number one would be CPAP, right, and weight loss. The pro, it's non-invasive, and if the teen loses weight, great, and it avoids a perceived risk of doing surgery in an adult that where theoretically may not work. The con is that teenagers, as you know, and I don't know how many you've treated teenagers, hate a lot of things, and they definitely hate CPAP and typically will not use the device. Now, the ENT physician was a good friend of mine. We went back and forth on this. He recommended this. He did not want to do the surgery, period. Next slide. Phenotype number two, which is I wanted because of my pediatric cat, not the adult cat, was doing TNA. Take it out, and if it still has residual disease, then you could work more on weight loss. You could go CPAP, and because now you've opened up his throat, you could potentially do an adjustable oral appliance. The pro is you may cure the kid. The con is the surgery may not work. He may have post-operative complications. There's about a 5% chance of the sutures breaking off and him bleeding. This is what I push for. Next slide. And the reason I went through this is basically, even when you go to up to date, they clearly say that no matter what the weight, and we've certainly seen this in younger kids, take out the tonsils and go for it because oftentimes you'll cure the situation. Next slide. So the ENT guy won. He won because he's saying as a surgeon, I don't want to cut you. So which kid is ever going to go to him or he would get a second opinion and say, oh no, I want to get cut. It was put on CPAP, worked well, he lost weight, everybody's happy. And then as a typical teenager, and again, I'm not biased, both my guys were teenagers at one point in time. And he said, I'm not going to do this anymore. You know, he was working, he has a girlfriend, he's playing music in a band. So he stopped CPAP, gained any weight, they came back, and now he's 20. So I go to him, hey, let's repeat the sleep study, see what happens. And he said, no, I'm done. I'm fine. And he's fine because obviously he didn't perceive being sleepy. So now we have no treatment on him. Next slide. So before I start with this, it becomes an issue because obviously how we approach this age in regards to sleep apnea and how our biases are of what the best treatment is can potentially help or hurt somebody's treatment. And this is an age range where it's oftentimes very tough to treat. And in fact, oftentimes I've seen kids in their 20s where if you're tired, oh, you're just depressed, you're just anxious, rather than getting into more detail what's going on. Now let's flip sides. Let's go to periodic limb movements. And the adult and kid criteria are the same in the scoring manual. We know exactly how to score a leg kick. It's interesting, though, that we make this whole point that, you know, they just leg kicks? Are they disorder? And part of the issue comes up is, and this group is actually the same, almost the same group of investigators. We get into the same problem where the groups have been looked at separately. So if you look at the classification manual, disease is significant in kids if they have more than 5 leg kicks per hour. In an adult, it's 15. So what do you call it 17? I mean, again, we're getting into the 17 years, 364 days. It jumps from 5 to 15. And in fact, when you look at how people read the studies, they clearly will say a 19-year-old with 8 episodes per hour of periodic limb movements, fragmenting their sleep, well, it's not significant. I've seen that happen. I've seen that happen with Vesna and her colleagues because that's how it's done. And in reality, that's a problem, right? How can you make that jump? Can the next slide? So there's a potential good news, and it looks upon how you look at it. The study was done in pediatrics again. It's a pediatric group looking at it. And we all know this new syndrome called restless sleep. And restless sleep is they're moving around like crazy and they're kicking. And they're associated with low ferritin levels. And when you increase iron stores and increase your dopamine production, hopefully the symptoms get better. And I've seen a number of these little kids and even older kids over above 18. It's not a phenomenon. Just because it was reported in 6 to 18-year-olds doesn't mean it doesn't exist in 5 and 4-year-olds, and it certainly doesn't mean it doesn't exist in 20-year-olds. But what you end up seeing is a spectrum. So you'll see very restless sleep, and my techs are great at recording it. And when the scoring techs score it, they see periodic limb movements. So they may see an index in a kid of 3 leg kicks per hour and maybe 30 leg kicks, let's say, for example, and 15 cause an arousal, and then they're restless the rest of the time. So you call it restless sleep. And in fact, if you think about it, that restless sleep description essentially gets rid of this definition because you're going to treat it the exact same way. If you have restless sleep with X number of leg kicks or you have periodic limb movements with restless sleep, it allows us to potentially get away from these cutoffs because your approach is the same. You're going to check your Fahrenheit level. In little kids, it's 50, and adults, it's 75. I always look upon teenagers as 75. And you push the iron, you give magnesium, you potentially give gabapentin based on the new thing out on restless legs and periodic limb movements. So there is some potential hope for us to blow up that definition gap in this condition. Next. Now, when do you switch a kid? Part of the biggest problem is, again, a lot of the pediatric sleep programs and adult sleep programs are literally in different buildings. I mean, for us, we're in the same building. Kids can be switched from the pediatric to the adult practice. I'm the transition guy. I can easily take an 18-year-old in college and put him in an adult thing. But the problem is how do you do this? So I have two kids, one who's a physician, one who's a finance guy. They're 31 and 33, and they were in a pediatric practice. And they literally tripped on a kid's toy, at a 6-month-old's toy, when they were in their teens and said, "We're not going to be here." So, okay, we'll go to Med Peds office. Well, then they're in an office with 50-year-olds with hypertension and diabetes. So it wasn't the perfect situation. And so how a kid gets switched isn't totally up to the kid because the way um, the structure is with practices, I can't bring a 17-year-old in, but I can bring an 18-year-old in. And the other thing that we have to be careful about with this switch is don't forget the parents. We say an 18-year-old should be able to make his own decision. Sure. 18-year-old can do what they want. Sure. I had a mother come in wanting to talk to me about an 18-year-old sleep study because the 18-year-old refused to come in. And I couldn't even talk to the mom because the kid hadn't give permission. So, but don't forget, even when the kid's in college, that the mom, the father, they've been so integrated with stuff that oftentimes they want to still play a part. So there's no great answer, but you have to think about that when they're switching. Next slide. And the other question is the adult practice really equipped for it? Can they deal with moms and fathers and kids in college? Next slide. So let's talk about the kids in college because that becomes a big part of this transition. Some pediatric practices may keep the patient while they're in college. Others may say, no, we're done. So first of all, just remember their patients' sleep patterns are totally different. Levels of excessive sleepiness in high school because they're sitting in class all day may totally be less or different when they're in college. It's the old thing like when we were residents and people in the military, hey, you eat when you can eat and you sleep when you can sleep. So a lot of this dozing off go away. You can also, in fact, though, have more delayed sleep days because they can stay up as late as they want to and change their classes to be um, uh, starting at 1 in the afternoon. The other thing is you're now dealing with accommodations. So they'll have roommates and they may need a letter saying they not only that they have to have their own room, but they need more time to take a test. And in fact, I have a second year med student at Brown who's my patient who literally we're dealing with trying to get Xyrem for her narcolepsy. And we had to get extensions. She's taking step one, and she can't sit and take the whole exam at once. I had to write a letter to the USLME to get it to over 4 days. And then, of course, they get more influences potentially with alcohol and drugs. So it's a different animal. Next slide. And then we get into the issues. How do you deal with their heavy duty meds? How do you go through pharmacies in other states? Sometimes the parents pick it up and mail it. How do you do that? It's not simple. It really isn't a simple thing. And you, as an adult sleep doctor or a pediatric sleep doctor, this is something we're not taught. And how do you get the kids to protect the meds in their dorm? A lockbox? How do you do with it? And then the big king one is sodium oxybate. Where does it go? Who gets it? Does the residential advisor sign for it? Does the kid have to be there? Does a faculty member get it? Does the post office get it? Do the parents get it and then ship it to them? And one thing I would strongly urge is I have Teresa, and you needed Teresa. Let me explain Teresa. Teresa is this wonderful girl who developed narcolepsy at age 15. And I took her from the kids practice to adult practice. She went to Notre Dame and she's a teacher, very successful, and she's my go-to. So whenever I have a kid in high school getting stuck on one of these drugs or going to college, I say to Teresa, "Can you talk to this one?" And she does. We hook up she agrees to talk to the patient. The patient agrees to talk to her. I stay out of it, and she walks them through how the meds can be stored, how to get it shipped to a pharmacy, how to have your parents deal with it, because she's done it all. And she again graduated from Notre Dame with honors and did this. So I think that one of the things you need as you're part of your transition, no matter which side of the fence you're on, whether it's pediatric or adult, you need a Teresa. You have to get one of these young people who have done this help you because we don't know. We're not in the college. They have a much better idea. Next slide, please. So part of the issue, I think, too, is we need to do a better job with definitions. This change from 1 to 18 and then 18 over really doesn't work, right? And we also have to make decisions about the teenage patients, not just on age, but who are they? Are they heavy? Are they thin? Do they have any medical issues? Do they, how well do they deal with stuff? And I do think the pediatric sleep people and the adult sleep people have to talk. I mean, how are they going to do this? Because kids get older. And we're not talking about, a lot of adult regular providers don't know how to deal with 20-year-olds. We have to be able to do a better job with that and make sure that we can do this, sleep physicians. I'm in an unusual position because I'm the transition guy. I'm the bull in the china shop who just takes the kids and keeps them going in the adult thing. But I think it's really important that even if you don't have somebody who does both sides, that you have that relationship set up so that the teenager can knows who they're seeing and the practices are really talking to each other. So I'll stop there and open for questions. And I'm sorry for the slide craziness at the beginning. I hope everybody heard me and were able to see the slides finally.
Dr. Millman, thank you so much. This was an amazing lecture and such food for thought. So I know you said we don't use the home sleep studies for kids, reasonable, but what with like the new technologies coming out, especially the rings that are FDA approved, where one night you have even moderate sleep apnea, then for 3 nights you have nothing, then again you have some events. What do you think, like where the future lies there?
Well, I think there's two questions here. One question is there new technology available? Sure, and we should embrace it. It's always a problem getting insurances to pay for stuff. I mean, I've been dealing with home recordings forever, and we've done a lot of research with even full polysomnography in the home. But the interesting issue is the other part that you mentioned. 1 night with sleep apnea, 3 nights without, right? And I think that one of the things is we all know there's a night-to-night variability in adults. What about in kids? Well, in kids, of course there is. And one of the things we have to be very careful about is taking a negative study and saying they don't have sleep apnea. I personally think the value of doing a sleep study in a kid is to look for other things to see if they have such severe sleep apnea that they need to be hospitalized, have the surgery in a hospital setting, be hospitalized afterwards, potentially in the pediatric intensive care unit. But I don't think a negative study means anything. And I'll give you a clear-cut example. My older one's 33. He, up until age 6, had the most disruptive sleep, had bedwetting, slept with his head back, really didn't snore. When you looked at his throat, the tonsils weren't big. And then at age 6, he gets a cold. And he gets a cold, and what happens is he has 30 episodes per hour. I'm counting them. And it turns out he had his adenoids taken out, and they were the size of golf balls. And literally all his symptoms went away. If you had done a sleep study when he was asymptomatic, which oftentimes we do, we don't we don't do sleep studies when they're really sick, we would never have gotten it. And I think that one of the things we do have to appreciate, especially in kids, that there is a lot of variability night to night. And you can make the argument, well, if we don't have it on 250 days, why are you taking the tonsil and adenoids out? I just think, what about the days that they do have it? And a question just came up on the screen. What's a complication in kids of TNA? It's about 5%. There's a 5% chance of bleeding. And I think that's one of the reasons why you got to make sure you know who your ENT doctors are. And certainly if you have significant sleep apnea, we keep them in the hospital overnight. And yeah, there's going to be some bleeding, but I think that you have to have a competent person. I mean, that's true even with surgery in adults. So is it totally safe? No, but no surgery is. But I think that I've seen kids who are overweight at 8 years of age have episodes of 50 episodes per hour. They take out the tonsil adenoids and they go down to one. And they're wide awake and no snoring. So it's a balancing act. I've also seen little kids who the parents say, I don't like the risk of surgery. They're going on CPAP. Well, now you have a 6-year-old on CPAP and now they're hitting teenage years and a kid says, I don't want to wear this. And now you say, well, the complication rate may be more, you know? So I think that it's I'm a big proponent of carefully done surgery on kids. And in regards to your original thing of technology, yeah, we just got to pay attention to that. The other question that came up was CO2 monitoring. It's an interesting issue, and this is where we get into things about definition. Um, I think if there's any neurological issues at all or hypoventilation, you do entitle CO2 or transcutaneous CO2 as much as you can. In regards to pre-teenagers, and I don't disagree with this at all, obviously events can look different, and it's crucial to have CO2 monitoring to look for periods of hypoventilation and stuff. Um, I think that it sort of, becomes, do you have to have it? I mean, we try to do it as much as possible, but once you start scoring it as adult and they really look like an adult, it's not required for adults and it gets very blurry and stuff. But clearly, if there's cerebral palsy, neuromuscular disease, anything where you're really looking for hypoventilation, the more you can have the CO2 monitoring, the better. Um, oh, Tanner Sagey. Well, that's interesting. So that data doesn't support that. I mean, when we looked at the data when we were using Thermistor to get it maybe different with nasal pressure transducer, we did do Tanner staging, and it really didn't make a huge difference because it's if you're it's not like you can going from 1 to 5. It didn't make a difference if you're Tanner stage 3 versus 5. I mean, once they start having some prepubescent or pubertal changes, we saw events. So. I don't think it really helps you saying, oh, I'm going to do kid scoring at a Tanner of 2 versus Tanner of 5. I just don't think the data supports you, and I don't think there's enough data on that specifically. So while people are still thinking, I think we as a field literally have to have a conference if you think about it, because we need to come up, we've made our definitions of adult sleep apnea independent of pediatric sleep apnea, but we made our definitions, if you think about it, by several consensus conferences. And we have tried to look at the apnea-hypopnea index versus symptoms and that. And you can't even do that because if you look at the sleep ahead study, where we had diabetics and we tried to determine who had sleep apnea or not based on symptoms and things like that. They practically all had sleep apnea because they're a little overweight. We published in our group a couple papers looking with Katie Sharkey and I and the surgeons looking at people going for bariatric surgery. We absolutely, using multiple parameters, could not determine who is going to have sleep apnea or not. So everybody going for bariatric surgery gets, before it's an in-lab study, now it's a home study to see if they have sleep apnea because it makes a difference how we approach them going on CPAP and how they do monitoring. So I think we're sort of stuck a little bit once you start getting into like obese people and things like that. So, but I really don't have a great idea because we just purely came up with um, we really came up with, this is the arbitrary rule. Now, what about daytime sleepiness? The question came up in a 15-year-old. Boy, you're talking really a tough situation because they're all tired and 100% tired. Why? Is because they're sleep deprived and they stay up too late. Their sleep need is 9 hours. They may be only getting 6 or 7 during the school day and more on the weekends. And give you an example of this, my guys were 22 months apart, 1 grade apart. So in 10th grade, one was a ninth grade, one was a 10th grade. They changed the curriculum so they both took the same math. I don't know, it was geometry or algebra. So my wife immediately ran into guidance and said, don't put them in the same classroom. So what they did is gave them the same teacher. One had him in the morning, one had the teacher in the afternoon. So in the morning one, my wife met with the teacher for both kids in the fall, and her comment was to my wife, boy, your afternoon kid is so much smarter and brighter than your morning one. And then after the first of the year, they switched and the afternoon became the morning became the afternoon, and the teacher apologized and said, "Oh my God, they're both smart. It's the morning that did it." And of course it is. That's the whole purpose of school start times, pushing them later and stuff like that. So I think it's very difficult to get a really great thing and even use the Epworth or anything like that. I think it becomes very hard and a lot of it becomes very subjective. Hey, they're falling asleep in class. That's a big one. They're falling asleep in the car. They're falling asleep doing their homework. So I think it gets to be interesting. And then the other thing that's interesting is the sleep field, the old sleep field. I guess I'm old sleep field because I've been in it since 82 or so. My older son was at Mayo Clinic for separate stuff, and he saw a sleep guy who said, "I don't deal with fatigue." This guy was older than me, so he really was an old timer. I don't deal with fatigue, I just deal with sleep. Well, part of the thing we have in teenagers is, and that's why the scoring doesn't become important as such, how sleepy they are. We deal with fatigue. I had this one teenager who, from one of the high schools, who kept on not being able to get through the day. He'd go home at 1, 2 o'clock, and we did sleep studies and MSLTs and everything like that. And we came up with nothing. Thyroid's fine, ferritin's fine. And then one day he shows up, and you're dreading seeing him because you've done nothing for him. And he's wide awake and feels great. He's no longer fatigued. And I said, "What happened?" And he said, "Somebody checked my vitamin D level. It was low and I'm on vitamin D and I'm wide awake." And so I think that part of the thing that happens, especially in teenagers, it's not just falling asleep, it's also fatigue. And I think our practice especially has moved a lot, not only in kids, but also adults, to look at those parameters, to look at exercise, look at ferritin levels, look at vitamin D levels. And you could argue that everybody in the Northeast is vitamin D deficient. Who cares? Well, it does make a difference. I think that the data suggested that vitamin D deficiency does cause fatigue, and increasing vitamin D helps. So I think I don't tend to look at how sleepy you are to generate a workup. I look at fatigue as well. And then it obviously gets blurry with anxiety and depression and everything else like that. So I missed something. I'm saying I'm a med-peds trained sleep doctor here at Yale, and I missed the ENT part. I'm sorry. Let me look at that.
I heard recently from an who practices in Boston that decreasing reimbursement rates for TNA in teens and young adults are affecting whether or not surgeons are even offering TNA anymore for them. How you run into this? If so, any ideas on how to combat it?
Well, I think that that's what we're definitely seeing in adults. And clearly, there's only one practice of the two, there's two major practices of ENT in Rhode Island. And one of them has like 3 or 4 board certified pediatric ENT, and then the adult guys don't want to touch the surgery. The other group is much more aggressive and will do TNAs and such. So the thing is, a lot of the surgeons are scared of this of discomfort and is scared of bleeding, and it makes it tough. I mean, we literally, if we wanted older kid, teenager done, we have to go with practice X rather than practice Y. But practice Y just hired somebody right out of his fellowship who doesn't care, and he'll operate on anybody. He'll say if their Southlanders are big and they have sleep apnea, we're going to do it. So I think it does require somewhat of finding out if you really somebody needs a surgery to find out who's willing to do it. And obviously, you don't want somebody who will cut on anybody. You want somebody who actually feels comfortable doing the surgery type stuff. I hope that answered that question.
And please feel free, everyone, to unmute and ask your questions.
So, let me just jump on this conclusion again. I do think we as a sleep field have to take the initiative of realizing we have an issue with definitions. Um, And I think that we as a sleep field have to come to grips with this. You can't have this disparity at age 18. And again, I think the restless sleep will help the issue with the periodic limb movements. I think having PLMS versus PLMD is silly. I think having a fixed number is silly. I don't think you should be calling somebody normal at age 19 with a periodic limb movement of 10 per hour. I think you have to look at why that is, and that's essentially looking at the restless sleep, whether they're restless, looking at ferritin levels, just like you would do if they had that. The sleep apnea is much tougher because, again, there's not a lot of studies in between. There's a lot of investigator bias, and I think we need to potentially do a study in that age range or have people take patients who have already been studied where there's any controls and really look at it because right now it is clearly one side versus the other. And I have a new colleague who's a pediatric pulmonary person, METAP, who's doing a sleep fellowship up at Boston. And I asked her, how are you guys doing with when she sits with attending to read it? And they don't really know how to deal with the teenager. They really don't know how to call it or not call it. Uh, and I think that because we don't have a firm cutoff, we have to come to grips with that as a field.
Are there any other questions? Dr. Millman, as always, thank you so much. It's always so interesting listening to you, and you always definitely shine light on topics that are not often talked about. So thank you for that.
Yeah, and I knew this was not going to be one that people are going to jump up and down and say, I agree with them or don't agree with them. I didn't want to. This is a controversial topic. This topic's almost like an op-ed. And people, and I hope that we do see some improvement in direction in the field with this. So thanks so much for having me.
Thank you.